very glad that we're having this particular session today because several years ago I came across dignity therapy, and it changed my outlook uh, on providing care in seminal ways. And I remember back then we had a program going on in Pallium, India, and that's when I met Dr. Seema Rao for the first time, and we had a conversation about it. And to me, Seema is a kindred spirit, and I can't think of a better person to take us through this session. Just by way of just setting the context, dignity is one of those things that has re-emerged as a theme in several of our sessions so far. We've done 25 sessions. This is our 26th, and it is central to the idea of providing holistic and compassionate care, because it is only when we take into consideration the other person's dignity that we can give that we can provide the care that is appropriate to them, in line with their value system, which is such an important part of palliative care. So dignity is something that is mentioned in our constitution in our country, and the right to dignity. But what is dignity? It varies from person to person. What is dignity to me is very different from dignity to somebody else. So it is one of those very nebulous words which we all know is very important. But if you were to ask different people what dignity means to them, every three people you ask, you'll get six answers. So to take us through this very important and essential subject is Dr. Seema Rao, who is now with Karunashraya in Bangalore. She has recently made the transition there. She's one of the senior palliative care physicians in our country. She is a psychiatrist by training, so that makes her doubly special in my opinion. So Dr. Seema, thank you so much for being with us today. I know you have a very, very tight schedule, but thank you for making the time. I'd like you to know that this is a very diverse group of people that you're addressing today. There are people from civil society groups, there are people from the healthcare system, there are caregivers, there are people with lived experiences, and all of them are here, very committed. They've all Attendance has been fantastic for these last 25 sessions, and each of them I know by now is committed to delivering the highest standard of palliative care in their capacity. So uh, thank you, welcome to this group, and I'm going to hand over to you. I'm here to co-facilitate whenever you need me to. Please ask me to come in.
Thank you so much, Smriti. Really a pleasure to be with all of you. And as Smriti said, dignity is a very important concept. And I was under the impression I would be speaking to social workers and psychologists. But anyway, I will alter it a little bit
Also,
as
they're also part of this group.
yeah, part of it. Okay, okay. So we can, I would like it to be more interactive. So you can put up your answers in the chat. And I think Smriti, you'll be there, right? We could,
Yes, I'm here.
yeah, yeah. You could read it out and we could take it forward like that. So thank you for the opportunity, Smriti, again. And let me share my screen. Uh, okay, yeah, there it goes. Is it visible now?
Yes,
Yes.
ma'am.
Yeah, yeah. So today, yeah. So what I will be doing today is just, initially we will go on to exploring the concept of dignity and how does this concept of dignity get affected in terminally ill patients, and we will just take you through what we mean when we talk about dignity conserving care. So this is what I have planned for the session today. So to start with, I will talk to you about, I'll just read out this. I know a little bit about a lot of things. I know a little bit about biology. I know a little more about psychology. I know of little gems in theology, but I don't know enough about you. So when we start dealing with patients or people who are ill, we know a lot of things about the disease, about what happens to people with the, what happens with the to the psychology or the mental status of people with the disease. Also, we know a little bit about theology. But actually, when we look at how all this, when we bring it down to the person, we don't know anything much about the person that we are interacting with or treating with. The whole journey in dignity therapy is about understanding that person who's sitting with you, who's much more than the disease that we think about or the treatment that we are giving. So it is about holistic care that we are going to talk about. So my first question, as Smriti said, if you ask what is dignity, you will get answers from three people, right? So I really want to ask, what do you understand by dignity? If you could put it up in the chat, please. What do you actually understand? What does it mean to you? Anything coming up, Smriti?
So yes, now people are warming up. Respect. Someone says respect. Two people have said respect at the same time. Then someone says respecting me as a human.
Yes. Yeah.
Being treated with consideration.
Very good. Yes. So keep put.
Yeah. Sorry.
Yeah. No, continue. Yeah.
The state or quality of being worthy of honor or respect. Self-respect to self and by others. So a lot of respect-oriented answers. Yeah.
Okay, so makes my job easy actually. Yeah. So when we talk about dignity, it depends upon, which lens we are looking at with. There are people who philosophy in there, lot of talk about dignity in philosophy. There is talk about dignity in politics, law, bioethics, everything. So I'm not going to discuss any of these aspects of dignity. What concerns us is about what does dignity mean in healthcare, right? So I'm going to confine myself to that talk there. So basically, when we look at dignity, we look at one basic concept of dignity, which is spoken about in philosophy. It is the moral inherent worth of that individual. You are, it's something that you are born with. Nobody can give it to you. Nobody can take it away from you. That has been the underlying concept of dignity all along. It cannot be measured. It is universal and it does not change. That is the basic dignity of individuals or human beings or the life that we talk about. That in bioethics or when we speak about philosophy, we talk about this basic dignity. But also there is another aspect to dignity, what we call as personal dignity. This personal dignity is dependent on your lot of the interaction that you have with yourself, with the people around you, and with the society in general. So this depends upon, the way your autonomy, your your right to self determination. It also depends upon how this universe treats you. That is, how people treat you when you are sick, or the healthcare providers treat you, and also how you look at yourself. Okay, so this is very individualistic and it is a personal sense of dignity that we experience. And this aspect of dignity can be affected by a lot many things. It could be affected by the political situation in the country. It could be affected by your health. It could, be affected by the social circumstances that you have. So this is something that can change, or that can be eroded when something occurs. So we are specifically talking about the personal dignity. So as you can see, and as you have put up in the chat also, there is multiple aspect to this word dignity. There is self-respect on one side, self-esteem, your self-image, your pride, your sense of autonomy that you experience, along with certain, like, the connectedness that you experience with the society. So it's a very complex, ambiguous terminology. But then how are we going to look at it in the healthcare system? How do we apply this concept and improve care in the healthcare system is what we will look at here. So in the healthcare system, when we define dignity, it is your ability to live in accordance with your standard and values, and how you feel when you go to a hospital or when you go to a doctor and when you're receiving care. It specifically depends upon how you feel about it. So what happens to a person with a terminal illness or who falls sick? I'll just talk about this Mr. Ali, who's a 70-year-old gentleman. He is the headmaster of a school. He has been diagnosed with CA lung. Okay, so this gentleman has, how a school teacher, school principal is. He's been given a lot of respect Children stand and say good morning, good evening, sir, whenever he walks. The teachers are very, show him a lot of respect. And now he goes to a hospital. He's coughing outside the waiting room. And with the COVID scenario, the minute you cough, people look at you, give you that look and move away from you. Okay. And then there is a 25-year-old lady doctor who comes in and says, Ali, please come inside and lie down in the bed. Okay, and he feels a little odd because this lady is so much younger to him. And Ali, please come inside and lie down on the bed. It's spoken of very abruptly. He feels a little disturbed. She asks him to remove the shirt and she examines him. Ali coughs and she says, you should turn your head to one side and cough, not cough at my face. She reprimands him. And then she goes and discusses with her consultant. This is a case of CA lung with cough, chronic cough. She never mentions the word Ali's name at all during that conversation. The doctor scribbles the medication and explains it to Ali's son, who has accompanied him, doesn't speak directly to Ali at all. Ali asks his son what the doctor said, and his son replies, Dad, you don't worry about it. We'll handle all this. You just take your medications and you listen to the and eat and drink healthy, be healthy, and don't worry about all this. We'll take care of everything. Ali is standing near the door. They are going out. He's standing near the door, waiting for his son to bring the car to pick him up. When the security guard shouts at him and tells him, Can't you stand on the side? Why are you blocking the gate? So tell me, with this one consult in the healthcare system, what happened to Ali? You can put it up in the chat box.
He was treated like an object and reduced,
Yes.
feeling of guilt.
Yes.
It seems he got hurt.
Mm-hmm. Okay. Yeah.
So far, yeah, that's what we have so far.
Yeah. So basically, what has happened is Ali's self-image of himself was disrupted, isn't it? He was devalued at every step. Nobody looked at him as a person. His sense of control over his life vanished the minute he entered into the hospital setting, or when he was diagnosed with an illness. The family assumed, in a good manner, they assumed control. But in the same time, what they did was they devalued Ali, and he lost a sense of autonomy there. So these are all the assaults to the degree to one's dignity, a patient's dignity happens at every step when the person falls ill. Right from what happens at home to what happens in the hospital, there is unknowingly there are continuous assaults in the person's dignity. And this is what we will be dealing with in this, and how can we ensure that this does not happen. Okay, so when we talk about dignified living or dying, during a chronic illness, we look at three different things. One, some of the things are dependent on the illness. It is how illness erodes a person's sense of dignity. It is because of the disease. Another is because of your individual strength that you have, and the way you perceive your situation. That can also affect the sense of dignity. And the third thing is about how the system or the society treats you when you have that disease. These are the three factors that you look at when you look at the dignity in the terminally ill person or in an ill person. So when you look at what are the major categories, one is how does the disease affect you? The disease can prevent you from thinking about, and it can affect your capacity. It can affect how you look at do your day-to-day activities. Some of the diseases like dementia, can affect your thinking, or any mental illness also can affect your thinking, and it can erode your sense of dignity, or your inability to take care of yourself. Your dependence on others are also one of the basic things that a disease can happen due to a disease, and can help affect your dignity. The second aspect of the illness is the pain or the nausea, the vomiting, or the symptoms that come out of the illness. That can also cause a lot of, like suppose Ali coughing in the hospital setup. That cough caused people to look at him in a different manner, and that resulted in his dignity being eroded. Similarly, psychological distress, when you have anxiety, your depression, sadness can also reduce your self-esteem, and you may feel that your dignity is assaulted. The patients can, it can affect. The second aspect is what we call as what happens in the society. As I showed you, how the society treats you, how the healthcare system treats you, the extent of social support that you get from your family and friends, and your perception of yourself as a burden on others. These are all the things that can cause an assault on your dignity. So basically what happens in an illness is it opens the doorway to your, to what we call as patienthood. From being a person, you become a patient. The world starts looking at you as a patient. Ali no longer exists. Ali becomes synonymous with cancer of the lung. So people start addressing, looking at him as a patient rather than as a person. Okay, and as I said, there might be physical as well as psychological distress that is caused, that can affect your sense of dignity, and your self-worth can get affected by this. The second thing depends upon how you look at the situation. So one of the things that with chronic illness, what happens is that you are no longer able to continue with your day-to-day activities. He may not be, Ali may not be able to go to school. So his self-image as the headmaster gets affected. He may not, as the head of the family, people may not listen to him. Everybody will take control of the situation and try to tell him what to do. So the questions that come in is, am I the same person I used to be? I used to be respected in the school so much. Today, nobody listens to me at all. I have lost my place in life. And the questions of, your pride gets assaulted when the 25-year-old comes and orders you around or talks to you rudely. When the security guards in the hospital shouts at you, there is your sense of pride gets assaulted. And you feel you don't have control over your life. And all this thing can affect how you look at that particular situation. So what does the patient do to ease the situation? There are various techniques that people use to cope when their dignity is assaulted. One is they try to normalize their lives as much as possible. Okay, even if I may not be able to cook completely, but let me sit and chop the vegetable and give. I want to be part of everything that is happening in the house. So if you have seen some sick people, they will insist on going back to work despite not being well enough. This is, they are an attempt to get control over the situation and to normalize things as much as possible. Some of them will find solace in spiritual or religious activities. These are various ways people will try to get back the dignity that they have lost. And the most important aspect about dignity is about how the healthcare system looks at the patient. Okay, so as you all mentioned, being treated with respect and kindness is extremely important. Also important is the extent of support that you get from your family and friends. Support does not mean being overprotected, not being allowed to do anything, but support means being able to the families understanding what the patient wants and allowing some sense of control and autonomy for the patient. Also, people respecting your privacy is also extremely important. The worry that you may be a burden on others, or what is going to happen to the family after I am gone. All these are concerns that they experience that needs to be addressed here. So generally what happens when patients try to talk about their concerns to the doctors, as you can see here, I'm so scared, please hear what I need, what I want to talk to you. Doctors or healthcare system, nurses, all of us are not very comfortable handling patients' emotions. So what we do, we generally shift it to pain or physical symptoms, and we don't give them a patient hearing or a listening. This is one of the things in the healthcare system that erodes the dignity of a patient. So one of the things Anatole Broyard explained was, to the typical physician, my illness is a routine occurrence, what he needs to see during his rounds. But for me, It is the biggest crisis of my life. I would feel better if I had a doctor who at least perceived this incongruity. He, if only he would give me his whole mind just once, bonded with me for a brief space, surveyed my soul as well as my flesh to get to my illness. For each man is ill in his own way. What we need to understand is that every individual suffering is very different. How one person copes with the disease and how another copes with the same disease may be very different. And what happens is in the healthcare system, we focus mostly only on the disease aspect of it, without trying to understand the patient's story. So, this is where we need to change practice and look at the person in front of us as an individual. Now, what stops us from doing that? One is we do not have the expertise to handle this extent of the emotions or the difficulties that the patient faces. We do not have the expertise. Another, we just want to get the work done, and we don't have the enough compassion or concern within us. And mostly it is because we are overburdened. We don't have the time, and we have too many patients, or so we don't have the time. And also there is a stigma of handling these things, or any other reasons why you think healthcare providers may not be focusing on this aspect of the individual. You could put it up in the chat. Any other reason that you think? What prevents the healthcare providers from focusing on the concerns of the patient in detail?
Lack of empathy,
Mm-hmm.
Vandana says.
Okay.
Lack of time. Oh, that's already on the screen. So anything beyond what is already on the screen? A little bit of emotional involvement.
Okay.
Someone says to avoid attachment.
Okay. To protect
Too
one.
many. Yes.
Yeah.
Overworked. If they only take time to see the individual as an individual,
Mm.
roots back to time. Somebody else has said too many patients to attend to, which is again time related.
Yes. So I think one of them, that is, I agree completely. It is about, lack of time and overburdened with the work. So you don't have enough time to address. But you have to remember that not all patients will require that extra time. When you do a round, there are some patients who are well adjusted and who manage, and you need just 5 minutes with them. Whereas some patients may be very distressed, and this assault on dignity may be very high, and they may be distressed. And in those patients, you may need to give more time. So it's about efficient management of time rather than being overburdened. So yeah. So how can we change our practice and help, and move dignity into care? How can we change our practice? There are three things here, what we call as A, B, C, D. So A is for attitude. What your attitude will determine, how your behavior towards the patient, and the behavior is the outward manifestation of your attitude. Compassion influences what you do. And the dialogue and how you express your compassion towards the patient through your dialogue will determine how the patient feels. So, actually, this is all connected. The attitude influences the behavior influences what you do, and then the dialogue that influences the dialogue, and then in the end the patient either feels validated by you, or patient feels put down by you. So all this is interconnected. Let us see how each one of us in more detail. Now, just a question. A 70-year-old gentleman comes to you for treatment. Do you take a sexual history in this gentleman? Yes or no? I would like to hear the answer. I'm really interested.
No is the immediate response from one person.
Okay.
More no's.
Okay.
He comes for what treatment though is the question.
Okay, so maybe he is coming for whatever treatment he comes, generally as part of history taking. Sexual history taking is an important aspect of history taking, isn't it? Whatever the problem is. So mostly,
So
isn't it?
mostly no's and one yes.
Okay. Okay.
All right.
So then let's go to the next question. I'm sorry for the spelling mistake there. Your patient is a chronic alcoholic. You see him confused and vomiting. What would you attribute the symptoms to?
Withdrawal.
Okay.
There are two answers are withdrawal.
Okay. Okay. So see, this explains our attitude, isn't it? It is what we carry with us, our presuppositions about something. What tells you that a 70-year-old gentleman cannot have a active sexual life, right? There is nothing that tells you they can't have, isn't it? But it is our understanding, our social learning that we assume that a 70-year-old may not have an active sexual life, so we are not going to take a sexual history. It is something that is there within us, isn't it? And but the second case, a chronic alcoholic coming to you, he's confused and vomiting. It could be metabolic disorder, it could be pancreatitis, it could be a lot many things, but first we will attribute the symptoms to his substance abuse. Okay, this is an attitude that we carry. Similarly, a patient with mental illness comes to us with a genuine problem. What we have seen is people attribute everything to the mental illness without looking at the physical, what other cause for the same problems could be. So this explains how social learning and how influences our attitude, and we carry our attitude into our interactions with the patient also. So we have to be extremely uh, aware of the attitudes that we carry. Okay, sometimes people who are when we how we treat a patient, our attitude towards our patient will influence how the patients also see themselves. Okay, we are like mirrors. How the healthcare system treats the patient perceives, look at themselves in the same manner. So if you devalue them, the patients will start devaluing themselves also. People who are treated like they no longer matter will act and feel like they no longer matter in life. They lose that interest to do anything. So as I said, patients look at healthcare providers as they would look at a mirror. They seek a positive image of themselves and their continued sense of worth from the healthcare provider. So when we interact with patient, we have to be very conscious about this aspect and try to foster or facilitate the positive self-image to the patient. If you wince when a patient comes to you with a wound, a very smelly facial disfigurement and wound, if you as a healthcare provider, make a face of disgust, the patient perceives it and will continue to look at himself as a person who's disgusting, like will look at himself in that manner. So we have to be very very conscious about what attitudes we carry. For example, I find substance abuse very hard to deal with. I become very judgmental when I see a patient who's has some amount of substance abuse, so I never handle addiction. That is something I have recognized in myself, maybe through personal experience or maybe through the prejudices that I carry, but I recognize it in myself and I avoid dealing with such individuals. So we have to be very aware of what attitudes we carry and ensure that these attitudes do not impinge upon our the care that we provide to our patient. So the question that you ask yourself is, in order to increase the empathy within you, you need to ask yourself, how would I feel if I was in this patient's situation? The second question is, why am I drawing this conclusion? Is it something in my past experience? Is it some prejudice that I am carrying with myself? Why am I drawing these conclusions with this particular patient? Why did I think this patient with chronic alcoholism is having withdrawal? So I need to ask myself that, and then I need to check whether what I'm thinking is accurate or not, and how will my attitude affect my care to this patient, and how it can hinder the relationship that I have with my patient. Once we start thinking in these terms, we will be able to change the attitude that we carry towards our patient. The second thing is about how we behave when we are interacting with our patient. Um, One of the important drawback of the healthcare system is we do things mechanically. When we examine a patient, if I was in a social environment, if I had to touch a person, I would have sought permission from the person before touching them, isn't it? Similarly, here you have patients coming to you, you examine them, you examine the abdomen or you examine the chest, you put a stethoscope. Do you seek permission every time you do that? Most of the time, 80 to 90% of the time, I'm sure doctors don't. They just mechanically do it, isn't it? And this is also an assault on the privacy of the individual. We have to remember that um, taking the blood or giving an injection or even simple examination is an intervention, and we are breaching the space of another individual, and we have to take permission before we do that. So telling the patient, excuse, I have to examine your lungs, I'm going to examine you, can I come close to you? Or seeking permission before you do it is extremely important. And treating patient with respect and kindness, instead of telling Ali, please go and lie down on the bed, could you, I mean, Ali, go lie down on the bed, you could say, Ali, could you please go and lie down on the bed, I need to examine you, drawing the curtains so that nobody else sees you. Okay. When you are examining the patient, respecting the privacy of the individual, all these are extremely small things that you can do in the hospital, in the wards, in the OPDs, to ensure that the patient's dignity is not assaulted. Also, when ongoing treatments are exhausted, generally what happens is in cancer patients, they come in for chemotherapy, radiotherapy. When all options are exhausted, the oncologist will tell them, now there's nothing more that we can do. You manage him at home. Okay, so it is sort of abandoning the patient when the curative options are exhausted. This is something that you should never do. Reassuring the patient that you would be with them till the end of their journey, whatever happens, is also respecting the individuality of that person and showing compassion. So whether it is talking to the patient, whether during examination, it is important to treat patients with respect, kindness, and dignity or integrity. So this is something that you need to do. That after attitude, behavior, then comes compassion. What is compassion? I'm sure in the last, how many sessions Smriti is over? 25?
25.
Okay, the compassion has come around quite a bit, isn't it? Would have come. So what is compassion?
To feel with, somebody says,
Hmm.
John.
Hmm.
Sympathetic pity and concern for the suffering or misfortune of others. Maybe we need to take that up a little bit. To put our legs in others' shoes.
Okay.
Empathetic view.
Okay.
Um,
Okay.
that empathizing with their pain. Yeah.
Okay. So what most of you have spoken about is empathy, right? So let me talk about, yeah, so I know that there's a lot of confusion about pity, sympathy, empathy, compassion. So I thought I'll put the slide in to tell you what compassion actually is. Pity is just acknowledgement of the suffering without much of emotional engagement with it. Okay, so I see somebody far away, somebody on the street, I feel pity for that person, but I don't have any emotional engagement with that thing. I just feel sorry for it. Oh no, such a shame that happened. That's where, and I'm done with. Okay. Sympathy, there is a little more emotional aspect of it that you put in. I really care about your suffering. Okay. So I'm sad and sorry that you had to do it. Again, you're not very much involved with what is happening. So the emotional engagement is a little lesser in pity and sympathy. Whereas empathy is what you all mentioned. I feel your suffering. I'm with you. I can exactly feel what you are going through. You know, it is frustrating, it is sad. I feel it. I feel sad. That is empathy. But is empathy just empathy enough to relieve a person's suffering? You know, palliative care is about relieving suffering. Once we feel empathetic, what do? We take some steps or actions to relieve that suffering. We don't stop at saying, I understand exactly what you're going through, but, and then leave it at that. That is just empathy. But when you take steps to reduce the suffering of that individual and try to help them out in any way, whichever way it is possible, it is called compassion. And as medical professionals or as human beings, it is the compassionate care that we need to provide. So empathy and compassion are qualities that you need to carry with yourself. I would say not only as palliative care physicians, but as individuals. Once you become a compassionate person, I think, I mean, though we in palliative care speak about it, as individuals for our growth, compassion is a must. Okay, so whenever you see suffering, you do things to relieve that suffering. Okay, so that is the difference between pity, sympathy, empathy, and compassion. I hope it is clear. Smriti,
I
do you
just wanted
want to
to,
come in? Yeah,
yeah,
I know you
I
want to
just wanted
go.
to come in with with one of my favorite all-time quotes, which is from a Buddhist nun called Pema Chodron. She says, and I think this captures it beautifully. She says, "Compassion is not a relationship between the healer and the wounded. It is a relationship between equals."
Equal, yeah.
And so, that's the thing that I think it's very important to also be mindful of the fact that when we are in a role of providing care, we there is an inherent power dynamic that comes in, and we should be mindful that that power dynamic does not, somebody who is sick comes to us when they're really vulnerable, and the healthcare system sometimes has a tendency to uh, for that hierarchy to come out in a way that actually assaults dignity. So to see the person in front of you as your equal, even if they may be economically far worse or health wise far worse, or are coming to you because you're the expert and they need your expertise, I think still seeing them as an equal is a really important part of compassion. So I just wanted to add that.
So exactly what we talk about in what we call as shared decision making. It is a conversation between two equals. Okay, you have knowledge about the disease or maybe the psychology or all those aspects, and the person sitting, you are an expert in the disease. The person sitting in front of you is an expert about himself. So the conversation is between two equal experts. He learns about the disease from you, and you learn about the individual, his preferences and goals from him. So it is not that I am a doctor or I'm a psychologist or I'm this thing, I'm at a higher pedestal. We are two equals. We are in a situation which is, and trying to make this um, suffering better of that individual better. So it's and as we know, palliative care heals. You know, both of us heal each other. The patient heals you, and you in a way heal the patient, and it's a conversation between two equals. Nicely put, Smriti. Yeah, so I hope the compassion is clear. And can we develop compassion? Yes, we can, by listening to narratives, by listening to personal stories of individuals who are undergoing suffering, by identifying. We may not identify with all stories, but we will definitely identify with some of the stories. And these are the ways that we can, develop compassion within ourselves. And how do we show compassion? Each look, gesture, touch, acknowledging the person beyond the illness, providing a very listening ear, and being with that person through their suffering is a very good way of expressing the compassion that we feel. And then from compassion flows the dialogue. And the dialogue should always acknowledge not the patienthood, as I keep saying, but the personhood. We have to acknowledge the situation of the patient as well as the patient. So I have an example where I will tell you how we can go about doing it. So using phrases like, when you acknowledge a person's situation or a patient's situation, they feel validated. This must be so difficult. This must have come as a shock. I'm so sorry that I have to tell you this. This is not the way I hoped things would go. These are the phrases that we generally use when we have to talk to the patient. I wish I could have told you something better, but unfortunately, the situation is such that I have to give you this news. And is it okay for me to go on? Acknowledging their situation and showing them that you understand. In addition to that, you also need to understand the person that you are having the conversation with. This person sitting in front of you is a patient because of the disease. Person who's sitting in front of you, what should I know about you to take good care of you? What are the things that is important to you? Who else should I who else in the family should I talk to? Whom do you want to be here to support you? And what other help other than the management of the disease, what other help that you do you need? So looking at the person beyond the patient is also extremely important, and acknowledges the patient's situation and acknowledges the person. It shouldn't be patient, but it should be person. I'm sorry for that error also. So these are the two things that you try to bring out in the dialogue that you have with the patient. Okay, and this I will talk tomorrow. So let us look at Naina's story. Naina is a 65-year-old lady. She has pancreatic cancer, which has spread all over her body. She also has Parkinson's disease. She has diabetes. She has hypertension, and she has kidney disease. Okay, she has been deteriorating progressively. There are a lot of tremors in her hands, and she's not able to move because of the Parkinsonism. And she has a lot of abdominal pain because of the pancreatic cancer, and the limb pain because of the Parkinsonism. She also has an infection in the lower limb, and that lower limb is swollen. And one trying to walk in her house, she fell and she has fractured the one femur, one thigh bone is fractured, and we are not able to operate that because of her disease. And during Parkinsonism, you get tremors. So when she gets tremors of the lower limb, the fracture moves and it causes excruciating pain for her. The husband reported that she was irritable, crying, she was refusing to meet friends, she was extremely fatigued, unable to eat adequately, not sleeping. They are a retired couple here in India. The only son is in USA, and she is well aware of what is happening to her. Cognitively, she is very intact. And she had been put on anxiolytics and antidepressants, but she is not able to tolerate because of a kidney disease. She becomes extremely drowsy with this uh, all this. So I'll tell you how we applied this dignity conserving care and how we managed her. So one of the things that we did is, see, none of this will work if the patient is in physical distress. Remember that much. It is as important as it is to attend to the psychological aspect and dignity aspect to the individual. It is also important, equally important, to manage the disease. She had severe pain. She had to be made comfortable. She had infection, which had to be managed with antibiotics. She had a fracture, so we had to look at treating that fracture. She had Parkinsonism, so we had to look at managing that so that the tremors will come down. So first, what we looked at the situation and looked after her medical aspects. The second thing, once we looked at the medical aspect and she was a little comfortable to converse with us, we asked her, how are you coping with and what is happening to you? She was extremely anxious. She was anxious because her son was supposed to come a month later and she didn't want to die before meeting her son. So this thought, disturbed her. She knew she was going to die, but she didn't want to die before meeting her son. She was unable to sleep. She was irritable because of all this. And then Are there things about the illness that you would like to discuss? She wanted to discuss about dying at home, not getting admitted into the hospital. There was a lot of things she wanted to talk about, which she was not given an opportunity to, and that was why she was feeling irritable. She had lot of support, but everybody kept telling her, you try to get better. No, no, don't talk about dying, don't talk about death. So she was not given a opportunity to express her feelings. So next came, I asked her, what should I know about you as a person to take good care of you? What should I know about you? So came, she was extrovert, she was creative, she was a painter. She ran a women's vocational group which was making handmade items like jewelry, purses, paper mats, etc. She had very good social support. There was a, every week they used to have a play, reading of a play in the house, you know, Shakespeare or whatever. She was not very religious and she loved to listen to Frank Sinatra songs. So one of the things that we started off with is, now that she was comfortable, we started off introducing, we had a reading of a play in the hospital setting. So the whole group landed up in the hospital next to her bed, and I also joined, went and sat through that session where we read part of a Hamlet or some play that it was going on. She started participating in it. And also she used to have this table mats. She used to paint this table mats. So we, since her tremors had come down a little bit, we reintroduced that activity in the hospital itself for her. The next step was, what are the things that are important to you currently? Today, what is most important to you? What do you want to do? She wanted to be physically independent. She didn't want to depend upon her husband or any other to go to the washroom or the toilet. Now, with Parkinsonism, with fracture, this was not a goal that we could give her, like, you know. So we had to compromise. What else? Suppose you can't go to the toilet on your own, what else would you like? So, you know, talking like that, it, what emerged was that she didn't want her husband to help her to go, help her wash up or help her in the activities of daily living. She felt it was an assault to her privacy. Then we offered her, would she mind, she didn't want any of the persons she knew to help her in that activity. So we said, okay, then would it be okay if we got an outsider to do it for you? We appoint a nurse or an IR to do it for you. She was okay with that because she did not feel indebted because they were paying her to do that. So then we spoke to the husband, whereas the husband wanted to help his wife. The wife didn't want that. We explained the situation and allowed appointed a IR to help her in these activities. So she was dependent, but this was acceptable to her. So this was something that we, who else will be affected? Of course, her husband and sons were her concern. We ensured that we supported them through this also. Are there things about you that this disease did not affect? She spoke about her role as a painter, as running this vocational guidance group. We ensured that she managed it in the, from the hospital. We reconnected her back to her life. So, and then listening to the music, taking part in the reading of the play, painting, all this was done in the hospital room itself. And also she had a wide set of friends, and she was not keen on meeting everybody. So we made a list of friends that she wanted her to visit every day. Some of them she didn't want to visit, so we, the husband and wife called up and told them that right now please do not come to the hospital, she is not comfortable. So we created layers of support for her, who would come and be with her during this time. And similarly, we looked at other aspects of her life, rearranging things at home so that she could be transferred back home, arranging a physiotherapist for home, all this based on what her needs were. So basically, the whole concept was, as Dr. Stuart Faber, who was a physician and then a cancer patient himself, said, what contributes to meaning and quality is not about living longer, but living a life that is consistent with my thread. Without knowing my thread, it is impossible for a clinician to provide respectful care. It is within the values and meanings of my thread that treatment decisions have to be made. So when we reach a point where, like what Naina was going through, it is important to understand that what her needs are and what her preferences are, and understand that and provide care within those needs and preferences. And that is when you are able to restore the dignity of each of that individual. So as I keep mentioning, there are multiple things that um, either erodes or improves a patient's sense of dignity. The whole idea of dignity conserving care is to, identify what is causing this erosion in dignity in this individual. One of the things in Naina was her physical independence gone, and her dependence on her husband for toileting and bathing activities were a major concern for her. Once we, removed that and kept an alternative, like understanding her needs, and stitched our care around what she wanted, we were able to, reduce her distress a little bit, much better than what the antidepressants or anxiolytics were doing. To connecting her back to her life, role preservation as we call, okay, connecting her back to being what she was before. Getting her in touch with her painting, getting her in touch with her that vocational group or the hobbies, were things that we could do even in an hospital setting, and that also helped in restoring the dignity in her. So similarly, for different patients, different things matter. Okay, and we have to understand what is causing the distress in this particular patient and try to reduce that aspect in that individual. So this is how, brick by brick, little by little, you can, restore personhood in that individual. So it's about giving the patient the treatment that they want rather than what you think they should be getting. That is what dignity conserving care is all about. Yeah, thank you. The other aspects of dignity conserving care, the empirical evidence about dignity therapy, I will speak in the next session. Here it was just a basic concept about introduction to dignity, what I wanted to speak about. Yeah.
Thank you so much, Seema. Honestly, one of the more soulful sessions. Thank you for so beautifully articulating it. You've taken a very, like I said, a very ambiguous concept and given us such practical ways of bringing it into our practice. So the floor is now open for questions, comments. Um, Seema, you want to stop sharing your
Yeah,
screen?
I'm doing that.
Yeah.
Yeah.
Okay. All right. So if others would like to turn on their cameras, it would be nice to see your faces. And also, if you'd like to unmute yourselves and chat with Seema and ask any questions, that would be great. So while we wait for that, Seema, I'm quite struck by a couple of things that you mentioned, which is, just circling back to when you talked about behavior. And, so much of the stuff that we learn in our communications class is nonverbal communication, which is behavior, which goes a really long way in how we communicate our respect and how we conserve somebody's dignity. And often I've asked people to use this example where when we used to have, back in the olden days, when we used to have residential classes pre-pandemic, when people were gathered there, a simple question is, how would you feel if you went to use the restroom right now and forgot to latch the door properly and somebody barged in? I mean, what would you feel? And the response is like, embarrassed, shame, anger, all of those things. And yet we see over and over again in settings, in healthcare settings, where a doctor will come with students, with the whole team, take off the sheet, change the catheter, in full view of everybody. It's almost like the minute the person has an illness, that none of these things actually really matter. So that's just a stark example. And in Pallium, I've seen nurses do this, where even if the patient is unconscious, they will speak to the patient before. And I know this happens in other palliative care settings, where you let them know that you're going to be touching them. And I've heard, nurses say the most tender things. to unconscious patients. And whether they can hear us or not, I'd like to believe that at least if they can hear us, that gives them some comfort and they still feel like people. So that was just an observation that I'd like to share. Um, I can see some cameras on. I'm sure people have things to say as well.
Thank you, Dr. Seema. That was a very insightful session. So I want to talk about how I suffered loss of dignity when I was going through my cancer treatment. I remember when I went in, I had to be radio ablated, and I was sitting there, and I will never forget that scolding for the rest of my life, Dr. Seema. I had to ingest some, a radioactive liquid, a lot of it, and I was told that not a drop should spill out. And going through something as big as cancer, and that time I was very young, it was been 12 years since, I was so overwhelmed, and in all that confusion, I left that pipe out. And the doctor who was there standing next to me, Dr. Seema, he gave me a mighty scolding. And for the rest of my life, I'll not forget that scolding. And because till date, I do not understand that why did he scold me? I was the one who was going through the treatment. He should have been supportive instead. He should have understood. So that is one that I wanted to share with you about loss of dignity. It's so important to be spoken to kindly with compassion when you're dealing with illness as big as cancer. Yes. So that is what I wanted to share with you. And thank you for sharing that and bringing it to fore and telling all of us about it, that how important it is for a patient's dignity to be preserved.
Thank you, Vandana. Do you remember the doctor's name?
I wouldn't want to say it.
No, I'm not asking. The reason I asked is, you may forget the doctor's name, but you will never forget how they made you feel.
Absolutely. So, I can still I remember crouching and on my chair like a scared child, and I have till date not understood. And I am, I'm a palliative, I'm counseling palliative cancer patients, and I would never do that to my patients, Dr. Seema, never in my life. So yes, I think probably a lesson learned. And also at that moment was also a realization that how important dignity is for every human being, especially somebody who's going through medical challenges.
So I would like to share one story of this young boy who was in the ICU. He had a congenital bone deformities. So he was very susceptible for fracture. This boy had a fall from a stairs and he was paralyzed from the neck downwards, and he was admitted in the ICU and he was referred to palliative care. So first day when I went to see him, he couldn't breathe, so he was intubated. That is, he had a pipe going down his throat attached to a ventilator, but he was awake. He could, converse through his eyes. So I asked him, "What do you want?" He kept, moving his mouth. So I understood that his mouth was parched. So I told the nurse, just wet some cotton and just, wet his mouth because it is very dry, like for him. Okay. And then he gave me a smile when that happened, and I came back. Next day, again, I went for rounds. As I was, when we went next to him, the PG who was there, the postgraduate resident went next to him, and I followed him. So he went, he said, he called his name, he closed his eyes, and he was sleeping. Okay, so he said he's sleeping. I said, okay, fine, he's sleeping. I turned to the nurse and asked, did he sleep in the night? Was he, how has the day been and all? He heard my voice. Now he couldn't talk, but he could make some noises. I heard some noise like this coming in. I was wondering where the noise was coming from. And then the nurse tells me he's calling you. He heard my voice. He didn't want to speak to any of the doctors, but he remembered I had, told about I tried to speak to him and talk to him. So he called me and I said, what happened? You want to say something? With his eyes, he said yes. He could move his head a little at that point in time. So I said, what happened? Are you in pain? He said, no. What I kept on asking, and then I said, "Are you getting bored?" He said, "Yes." So I said, "You want to see something, some TV, you want something?" He said, "Yes." "What would you like to see?" Then he moved his mouth. I could read his lips. He said cricket. So cricket match was going on. He wanted to watch cricket. He was not worried that he couldn't move his hands. He was on intubated tracheostomy. He was connected to a ventilator. He was not worried about any of those things. He wanted to watch cricket. Okay, so then I spoke to the ICU people. We gave him a small mobile. We put the cricket match on that and gave it to him, and he was quite happy with that. So what I am saying is that it's about looking at them beyond their illness. We would have
Yeah.
assumed he would be depressed. This guy was very happy. He was okay with being quadriplegic, but he wanted to watch the cricket match. So small things that matter. And also the fact that just I went and spoke to him and asked him what he wanted, and his mouth was dry. My attention to that made him more comfortable to ask for something the next time. So the end of the story is we got him operated. Finally, he was able to get up and walk. That is the different part of
Oh,
it.
lovely.
On other part of
Wonderful.
it, which is a huge success actually. But at this point, there are so many of them. We think they have no needs because they are in a vegetative state. But as Smriti said, you never know what they hear and what they perceive and what they feel. So whatever the state, it is very important for us to be compassionate, not just say that I feel for him, but do something to help them overcome the distress or suffering that they feel.
This reminds me, this 2 days ago, I had a call from somebody talking about a friend's father who was in an ICU in a very big hospital in a very big city, saying that he's in the ICU, he had a stent put in, he came home, and then he had a massive hemorrhage, so he's gone back. And this man is experiencing extreme thirst. And the ICU people just, they're like, no, no, it's fine, it's fine, it's fine. And she said, I don't know what else to do. I'm going to call you. And I said, I don't even work in critical care settings. She said, yeah, but he's so thirsty, his throat is parched, and to the extent where he's told and they're not giving him water because they're afraid he'll aspirate. And, so he's just there. And so apparently he's told his wife, even if I die here, just make sure you give me a glass of water before I die. So she said, what do we do? And he's not in a life-threatening situation at the moment. I actually called I actually called Dr. Roop Gursani and I called Dr. Raj, and we had these conversations separately. And of course, they both came to the same conclusion, which was the man is, he's probably his sodium levels are on the higher side and stuff that I wouldn't be able to tell. But the thing is that his sodium levels weren't low, so it was not dangerous. And everything, all the other parameters are fine. So who cares if this man is thirsty? And I couldn't believe, none of us could believe that someone was calling us regarding a patient in a big hospital, in an ICU, in a big city, and calling 3 palliative care people in completely different parts of the country to get this small, simple tweak done, which is like, ice chips in the mouth and yeah, just, hydrate, whatever. So it was, I think it's stunning to me that those kind of things, and the fact that the man is saying, if I die, give me a glass of water because, this is what I want. I don't care about anything else. Just to take the conversation a little in another direction, taking off on what one of someone has mentioned in the chat box, Sudha, that I'm also really appreciative of the fact, Seema, that you talked about your own boundaries with people with substance use, and it's a tough topic. It's a tough area. In fact, we actually had a conversation about substance use and substance use people with substance use issues, and I find that it is an act of tremendous grace when a physician of your caliber or anyone in the healthcare profession understands what their boundaries are, and as an act of respect says, I will refer them to somebody where my own counter transference will not come in, because we are human. There are things that we are uncomfortable with, and that's perfectly all right. And to pretend that we're okay with something beyond what we are actually comfortable with, I think takes a lot of grace to admit it. So thank you for modeling that for us today so beautifully. And that's just a reminder for all of us to also be okay with our boundaries, whatever they are. So yeah, I just wanted to mention that. There's a couple of more comments in the chat box. I think you have
Yeah.
access to it now. Yeah.
Yeah, I just wanted to mention about our just a young 34-year-old police officer from Assam who came here at our Vashi Arogya Bhavan for treatment at the private hospitals. During this stage, due to the surgery and other treatments, he had lost his hair, and he had even become very weak. And as he was a public figure like at Assam, and when people would ask him, it would be more of with sympathy, and he never liked that because he was in an armed Assam police cadre, so that sympathetic attitude, he never liked that people would, oh, what's happened, Partho. So then whenever we used to chat, I would go to his room. I would find that he is very keen, he's a very good writer, and he would like to convey in different, like he has written different books as well as in the newspapers in the local language about our NGO, that what work is being done. So he tried to divert his mind through literature and writing poems. Another aspect is that he found therapy in colors. And suddenly I find this guy very, wearing smart shirts and sometimes half and full sleeve and with lovely colors every day. So when myself and commissioner, we used to just sit and watch, and he would say, can I just enter and be with you all for the discussion? And I would just, I was amazed to see the same person who used to earlier be in such light colored shirts, but now he's all with the orange, blue. Imagine the difference. And when I said, Partho, you look so handsome. And it made a difference. Still his, I could say, I just waved him maybe by mentally, not physically to him. The last I saw, but he was so happy and confident. So the color therapy, I can say, really makes a difference. So, and now even in spite of he has passed away, and I was in Assam that time, and I could witness, the crowd which had gathered from the police force, and the dignity with which he is faced, was, I could remember all those words we shared together. And his old parents never thought that he would pass away so soon. But his wife, even till date, and she's a lecturer in the colleges, but she wears all bright, those meklas of Assam. So still I see her and she posts those, pictures along with him of all the bright memories as well as the attire, I can say. And it feels good even today to see that. So this is what I would like to share, Yeah. Thank you, Dr. Seema and Smriti ma'am, for really giving us access to such wonderful sessions. It's always looking forward to Pallium. Thank you so much. Yeah.
Can I, let's see. Yeah, and someone else.
Go ahead, Vandana. I'll wait.
No, go ahead, Shreya. I've had my chance after you.
Yeah. For me, I would say I had my heroes as Florence Nightingale and Mother Teresa in the school days. And I failed 2 years in the 4th and the 8th grade. And my elder brother thought I might fail in the 12th grade. So all that gave me the confidence much more to face life and to show the empathy and compassion what you spoke about. So I would always put myself in the other person's thing much before it could even happen. So I actually had what later on I came to know through Smriti's speech, I anticipate or being over vigilant. That was something very new to me, and I perfectly fit into the box of that. And right now I extend help and I tell people I'm there, but I don't go beyond. But if they want, I'm totally on the other side. So I think my failures and the way the teachers took me in school, I never changed school. I stuck to the same school till the end, be it the 4th failed or the 8th failed. So I would say those two helped me apart from one teacher. So I would say to what you said to Vandana, I had aversion to my mother tongue, which is Tamil. I couldn't get that language and I attributed to the teacher. I could never forget a name that I still keep in with her, not even to my own batchmates, but to the people whom I teach Tamil, who are much, much younger. and who are not even from the same school. The moment I take the book, I start perspiring, sweating. I can feel my heart palpate. It hits the chest wall. I said, okay, I haven't changed from what I was as a 13 to what I am 48. It takes some time till I picturize Miss Birdie, and then I'm able to go ahead with the teaching or whatever it is. So I totally understand. Your session was wonderful.
Shreya, you've highlighted such an important point, which is children have dignity. And that's something that we often, we associate dignity with older people. Children have a sense of dignity. And I think we oftentimes as adults completely overlook that. Seema, do you want to come in on that?
Yeah, definitely. So I guess that's what it's about. As I told you when I explained what happened to Mr. Ali, like right, the people once the same thing keeps happening to children. Also, when there is a family in conflict, we hardly speak to the children in that house, right? We talk to the parents and we expect it's children are always overlooked, but children also carry a lot of individuality. They need sense of control. They need to be respected, especially when we get pediatric patients. It's extremely important to ask them what they want, to explain to them. In fact, we had this 13-year-old, not 39-year-old, who had to undergo radiation. And he was sort of, he didn't know what was happening. Nobody told him what is happening. And he was in a panic mode. And they were calling an anesthetist to sedate him so that he could be taken for radiation. But somewhere uh, he happened to be referred to palliative care. And while talking to him, we understood that nobody had explained to him what was happening. Sitting down, explaining with him, asking him whether he would like to see the machine before he would go there. He said yes. We took him there, made him touch it when it was switched off, the radiation machine. He went in, he saw what was happening, and giving him a choice was extremely important at that point in time. And believe it or not, when the time came for him to receive radiation, he went in without sedation. So sometimes the uncertainty creates a lot of panic in children also, and we sort of tend to ignore their needs completely, whether they are patients themselves or whether they are accompanying the parents. We sort of, they are invisible actually. So it's extremely important to speak to the children, to find out, explain to them, and treat them like they were not adults, but treat them as individuals also.
Yeah, that's so right. And I think this is where we need to equip ourselves with the language to communicate effectively with children. And it doesn't have to be, adult language. It doesn't have to be full sentences. It's just about understanding what they understand, what their fears are. And we recently had a webinar with somebody who was a childhood cancer survivor. And, we asked him, because nobody had told him about his illness. And I remember prepping for that webinar, and this is a part of the story that came out. Was what was your biggest concern while you were going through the illness? And he said, going bald. I didn't care about anything else because I wanted to be like all the other kids, and nobody explained to me that my hair would grow back. I was so scared that my hair would just never grow back. And that is tied with a child's dignity. And another incident, one of my earliest lessons in Pallium was there was a child who with juvenile rheumatoid arthritis, and he was being carried by his mother everywhere. After a while, there was just really no hope for any improvement on that front. So he had to transition to a wheelchair. So we got him one of those pediatric wheelchairs, very colorful, this, that, and we got him excited about it. We had long conversations with the mother. We had forgotten to have a conversation with him. And when the time came for him to use the wheelchair, he was just like, we couldn't understand why he was not responding to it. And his concern was that now he was going to be a wheelchair user for the rest of his life. And he was 8 years old when we had that experience. And so I will never forget the fact that it meant something to him to transition to that wheelchair as well. So thank you, Shreya. I think you triggered this conversation, a very important part of it. And thank you, Seema, for carrying it forward. We have another few minutes if anybody else would like to come in with any particular questions. Vandana, I think you were saying something earlier. Sandhya is...
Yeah. So
yeah. Okay, I think I'll let Vandana go. She wanted to say something.
No, I've had my turn. You go, Sandhya. I can speak if there's time left. I thought there's no one else.
I'll just take two minutes maximum, I guess. Hello, Dr. Seema. I'm very happy, and I mean, it's so overwhelming to hear you talk, and it's a very nice experience. I want to say what happened to me. About 8 years back, I had undergone a mastoidectomy on my right ear. So when I was back then, I was in college. So I was one of the biggest hospitals in Chennai. I was in one of the biggest hospitals in Chennai.
You're muted, Sandhya. You just unmute yourself.
Oh, sorry.
Yeah.
Yeah, I don't know where you heard me.
You underwent mastoidectomy?
Yeah, mastoidectomy on my right ear. So I was in one of these biggest hospitals in Chennai, and I was a student there in the college, so I had to go to the same hospital. And when I went there, I wasn't sure what was happening to me. I had severe giddiness, giddy heads. That was because of the imbalance in the middle ear. So, and when I went in, the doctor came in, he checked me. He did not speak a single word to me. But then he brought in about 8 students and he started showing them something on the screen that I did not relate to it at all, because I'm basically an engineer. So I don't know what was happening. And these young students were asking me if they can picture the scan reports and stuff like that. I got at that moment, I just lost it. I don't know why that happened to me. I walked out of there. I told them, I'm not taking treatment from you guys. And recalling that experience still gives me nervousness.
Thanks for sharing, Sandhya. That would have been a very difficult experience for you at that point in time, and that's something precisely what I try telling all healthcare providers. That sometimes we look at only the disease, not the person with the disease. It's extremely important. That is where this dignity conserving care is close to my heart. It changed not only my perspective, but I've become trying to change every healthcare provider I meet, right from the security guard to the nursing staff to the receptionist. I keep telling them, look beyond the person. Would you do it to your grandfather if he came? Would you call him by his name? I was call, we wouldn't, isn't it? So if we meet in a social circumstance, would you call a 70-year-old by the name? Or would you speak in the same manner to a 70-year-old? The other day, I went to the ward for rounds. I saw a 17-year-old. Her parents were with her. She was wearing the hospital robe. The whole back was open of the hospital robe. Okay, so I just asked her to sit up. I tied that and I covered her up. And I told the parents, would you have done this outside? If she had worn this, what would you have done? Right?
Yes,
Why
doctor.
is it that when the patient enters into the hospital, even relatives also forget? It's not only the doctors, the whole atmosphere changes. It becomes, it's a patient then. It is not a person. It's not a 17-year-old girl. Right? And
Yes, doctor.
that's where you need to teach, and then I tie it up, and then everybody comes in and covers, or you remove a blanket to examine. You need to put it back up,
Yes, doctor.
right? Not leave it open like that and walk away. These are things that we need to train our young doctors in all this. And I hope people become more and more aware of what they do, so that we are not objects, not objectify people, and treat them as individuals. Yeah.
Yes, doctor. So that later when I came down to Coimbatore, it was a completely different experience. So there I underwent the surgery and I'm completely all right. But recalling that day, it gives me tremors. Thank you, doctor.
I think patients tend to lose their individuality. In a hospital setting, a human being, for example, Vandana becomes a patient. You're not identified as Vandana at all. And that is a huge blow to the dignity. I mean, I don't want to be like 200 more people there. I want to retain my individuality. Vandana is Vandana, and Seema is Seema, and Smriti is Smriti. So I think that's so important. Do we still have time? So yes. So I am presently dealing with a case like the last case you discussed with us, Dr. Seema. So it's for a 70-year-old man who was diagnosed with carcinoma of the bladder. So he has been, I've been counseling him from the day the diagnosis was made. He did not want the bladder removal. So, we everybody gave him that space to decide for himself not to get the bladder removed, although the family insisted. So I had a long conversation with the family that he doesn't want it. He's 70. He says, if I can, I live with the bladder and we'll just undergo chemotherapy. Unfortunately, post the surgery, there was metastasis. He had to get the bladder removed. And just last week, his daughter is a very dear friend of mine. She called up and says, he won't talk to anyone else but you. And then I got talking to him, and he stopped eating, Dr. Seema, not talking to anyone. Even, when there isn't pain, he screams out in pain in spite of being on pain meds. So I had a long conversation with him. So first thing I asked him, do you feel like crying? He said, yes, I do. I said, what happens when you cry? He says, everybody in the family starts sermonizing me, don't act like a 2-year-old, which is so unfair. I mean, we don't give the space to a patient to grieve. He's been through so much. At 70 years, to have a urostomy bag attached to your body, that in itself is a loss.
We've lost Vandana, I think.
Yeah.
Yeah, I think so. I think the whole point of the dehumanizing aspect of the loss of individuality, it extends beyond the patient also to the caregiver. And we have this very ugly word called bystander, which really needs to leave our vocabulary when we when we provide care. And I say this almost every third session that I take, is that it's such an ugly word, because it really diminishes what a caregiver really does. He or she is not somebody who stands by and watches. They're in the fight, they're in the ring, they're going through all the torment and trauma. So if there's one thing that I will urge everyone to do, is just take that word out of your dictionaries and vocabularies right now. Yeah.
And also
Since,
address the caregivers by name. That's something that you need
yes.
to do. Very important. Like, now some people don't even know the name of the person, their doctor's name of the person they are talking to, and what the relationship is. So knowing the name of the caregivers, calling them by name makes that personal connect happen. Like today, I saw a patient here in Karunashriya. I went and asked her, how do you like to be called? What do they call
Hmm.
you at home? She is a 80-year-old lady. What do
Hmm.
you want me to call you? So instead of, her name is Jahan. Karke. So what do you want me to call you? So she said, call me what mother, like ma bulao. ठीक है माँ जी. I said, ठीक है माँ जी, अभी बताओ. Like, so asking them what they want us to call them, sort of, for a minute, she was stunned when I asked that question.
No, but also must
And
want
then
her
that
to.
cute smile on her face, call me Maji karke. So these are things that will reduce the suffering. See, you cannot take away the disease. You cannot take away the fact that they may be in pain. You cannot take away the fact that the span is limited. But you could make the journey much better by, changing. And it doesn't take much time. It just takes
Yeah.
a little bit, 5 minutes extra of your time, and a little different words that you use that gives a lot of validation for the patient as an individual. And
And
one
also
of
at a time like this, yeah, it also builds trust and compliance, Seema, don't you think? Because they trust you more. Yeah.
Yeah. And one of the things that I noticed when I was working in Tata Memorial Hospital is the file number used to flash before the patients come in, and the patients are addressed by the file number. I I think that is the most dehumanizing thing that I really, would get very upset with that. The number would flash, not even the name of the individual. I hope they've changed it now.
They haven't, Dr. Seema. They haven't. They ha they haven't changed it, Dr. Seema. It's still the same.
Still the same.
I volunteer at Tata Memorial with the thoracic department, and it's still the same. It is CS5521. So that's the identity of the patient.
Vandana, you were telling us your story when you got disconnected.
Yeah.
We'd like to hear it.
Yeah. So then I asked him, what else bothers you? He says, I'm unable to eat. Because he's been through so much, and because of the bladder removal, his entire digestive system is readjusting, but the family forces him to eat. So again, you are taking away the right to make a choice from him. It's not that he doesn't want to live, but at that moment when his body is healing, we need to give him the space. If he's okay eating one chapati, let him eat one chapati. Maybe you could try after some time. So, and also the guilt that he was carrying, that I've become a burden on everyone else, that was also weighing him down so much. So I think all these factors together attribute to loss of autonomy, loss of dignity, and somewhere in trying to be overzealous, in trying to be overprotective, sometimes the caregivers also forget. So it is very important for the caregivers to give their loved one that space to heal. Sometimes you just need to step back and let them express themselves. So that is what I wanted to share. I could go on talking about him. Call him uncle.
Thank you, Vandana. So Seema, thank you all who spoke, who shared. Thank you for your comments. And you'll be very happy to know that this is not the last of Seema that you're seeing. You're seeing her again next week. So, so that's something to smile about as we go into the weekend. Seema, any closing comments before we bring the session to a close?
Nothing much other than I really enjoyed today. The interactions were very nice, and I really enjoyed the session today. And I hope one thing that I guess that we need to take back in our practice is, just be very conscious and mindful of how we treat our patients. Just start by calling them by their names. It's a very simple thing, call individuals by their names. I think that one step will make you understand what they are. And and it also opens up the space for more conversation. When you talk, hello, call the patient by the name, how are you? And you see the response that you get, the connect that you can make when you call an individual by the name. I think that one practice can change a lot of things in our dehumanizing hospital setup.
Thank you, Seema. Wise as always. And we look forward to your next session. So I'm not going to say goodbye. Thanks everybody for being here today, and look after yourselves, everyone. It's tough times for everybody. So be safe. There's a feedback form, Manisha, that needs to be filled. Yeah, so don't forget to fill that in, and we will see you next week. So take care, and bye-bye, everyone.
Thanks, everyone. Bye. See you all next week. Thanks, Dr. Seema and Smriti specifically.
Bye.